Hello, my name is Richard Stone, and I'm at Dana-Farber Cancer Institute in Boston. And I'm honored to talk to you about a disease that I'm very familiar with and have treated a lot of patients with, namely acute myeloid leukemia, which we'll call AML. Here are my consulting relationships. Now, what is leukemia? It's an overabundance of white blood cells, which are infection-fighting cells, in the peripheral blood. If the cells are immature, that look like stem cells, nondescript cells, we call that acute leukemia. If they're more mature, we call that chronic leukemia. And the acute leukemia is divided into AML, which I'll talk about today, and ALL, which is more common in children than adults. Chronic leukemias include chronic myeloid leukemia and chronic lymphoid leukemia. Other chronic leukemias of the myeloid lineage, besides CML, are myelodysplastic syndromes and myeloproliferative neoplasms. And we think about this in the so-called hematopoietic hierarchy. This is a very schematic derivation of this, but it's really telling us that the job of the bone marrow is to make the cells on the extreme right or the extreme left of this slide. On the left, we have our red cells, erythrocytes, our platelets, our bleeding prevention cells. And on the right, we have some of our immune cells, our T cells and our B cells, our basophils, eosinophils, and neutrophils. The last three on the right are the myeloid cells, and the neutrophils really are the main infection-fighting cells that prevent infections from bacteria and fungi that live in our own body all the time. As we all know, we have those. The AML is a problem in eventually making neutrophils. The progenitor cell to the neutrophil making cell becomes neoplastic or cancerous, which can fill up the bone marrow and the blood and thereby lead to bone marrow failure, which can be pretty terrible. So AML is on the top here. You need more than 20% leukemic cells or blasts in the marrow or blood. And again, the blasts are normal cells or can be normal cells. All of us sitting in the room today have up to 5% blasts, 4% or less. But if you have more than 4%, you've either got MDS if you're up to 19%. But we just like to say that if you have more than 20% blasts in your blood or bone marrow, you have AML if these are myeloid blasts. So AML is unbridled proliferation of the stem cells that are destined to make myeloid cells, which I talked about, result in bone marrow failure and will kill the patient unless successfully treated. Now, here's a very important thing. The risk factors for AML are age. It's a disease of older adults. The median age is about 70. So a lot of our therapies have to take that into account. About 10% of patients have a little bit of an interesting etiology. They've either got prior chemo for other cancers, they've had radiation for military, industrial, or therapeutic purposes, or they've been exposed to industrial solvents in a factory. That's why it's been thought that men have a higher incidence of AML than women. And now we know that a small number, but a significant number of patients actually have AML predisposed on a hereditary basis. That's a new finding, actually. So it's important to take a good family history. Then we have some special microscopic things under the light microscope. We can guess whether it's AML or ALL. We do special enzymology to figure that out. We do flow cytometry. The actual numbers aren't important, but suffice it to say, with a combination of light microscopic, enzymologic, and flow cytometric, which is deciding figuring out what proteins are on the surface of the cells, we can figure out whether we have a blast that's a myeloid blast or a lymphoid blast. And of course, as I said, bone marrow failure means you don't make neutrophils, which can cause fevers. You don't make red cells, which can cause anemia, producing fatigue and shortness of breath. You don't make platelets, which can cause bleeding, and some people have metabolic abnormalities as well that we have to check for in the blood and deal with. Now, this isn't that important for patients to know about precisely unless you're a scientist and a patient. But we now know a lot about what makes AML cells tick, thanks to work done in the last decade about what DNA molecules are abnormal in leukemic cells. And that's called mutations. We make a big deal about what mutations given patient's leukemia cells now, because that can tell us a lot about prognosis. It tells us about pathophysiology, which I'm not going to go into today. It can also perhaps lead to certain specific therapies. And this is personalized medicine, which we can now do in AML. When a person with AML comes in the door, we need to know what their comorbidities are, what their age is, what their family history might be. We want to know the blast cytogenetics, which are the gross chromosomal changes in the DNA. We want to know whether it's primary disease, which means they have no prior history of hematologic disorder or therapy for other cancers, or secondary if they do. And we care a lot about the mutations too. The three big ones are FLT3, ITD, NPM1, and CBP alpha. The first one is unfavorable, the next two are favorable. And then there's a bunch of other ones which we looked at now, which are unfavorable. And we'll be looking at more and more. Now let's, in the last 12 minutes, talk about therapy for AML. We have, in most cancers, we give repetitive cycles of the same thing to try to cure the patient, like the lymphoma. In AML, we have sort of two phases. One is induction, when the patient comes in usually ill with a high white count, perhaps sick from fever or infection. We have to give them induction therapy or initial therapy to reduce the gross leukemia from about 10 to the 12 cells down to undetectable levels of the light microscope, which is about 2 or 3 logs or 99.9% of cells getting rid of them. But we still have a lot when they're in remission. In other words, when we can't see the cells on the light microscope in the marrow or blood, we still have a lot of cells left, and we have to deal with those cells somehow by giving more chemotherapy or possibly a stem cell transplant. And we talk about remission. Remission isn't cure. Remission is getting rid of a lot of the cells. But now we talk about this MRD negative remission. What do we talk about here? Well, so remission historically just meant seeing the cells not present anymore, using the bone, doing a bone marrow, looking under the microscope, not seeing any extra leukemic cells. But we know that one person's remission is not the same as another person's remission. This is a big topic now in our therapy. We want to know how low the leukemic burden has been reduced by the initial therapy. We can tell that by some sensitive techniques called flow cytometry or molecular techniques to look at very small numbers of cells. So that really is the goal of therapy today, is the MRD negative remission, if we can do that, because that's going to bode well for a long-term outcome. Now, patients with leukemia come in sick with infection and bleeding. We can deal with that with antibiotics and platelet transfusions. There's something you might hear about called tumor lysis syndrome, which is actually more common in the kidney leukemia, the lymphoblastic leukemia, where we have to give them fluids, allopurinol, to prevent the breakdown products of the leukemic cells from harming the kidneys. So we can all do that now very well. There's one type of AML that's kind of, if you will, good. At least it's good initially if you don't have a problem. It causes severe bleeding. It's called APL, acute promyelocytic leukemia. That's one of the bright spots in leukemia therapy today. It's highly curable with a combination of retinoic acid plus chemotherapy, based on a seminal paper by Dr. Lococo from Rome in 2013. So just retinoic acid and arsenic trioxide actually beat retinoic acid and chemotherapy in this trial. And it's a little complicated, but if you look at the top, which is now our current standard, it's a lot of arsenic, which is given intravenously at the moment, although there's an oral formulation in the works. And the pills of retinoic acid, which is like a vitamin A analog, and the Kaplan-Meier curve here, which indicates a very long-term, positive long-term survival, 99% survival with this type of leukemia treated without chemotherapy. It's amazing. Hopefully we can recapitulate this in other leukemias. Unfortunately, we have a lot more work to do in our 90% of non-APL AML. A few years ago, we had like one flavor. We had so-called anthracycline and cytarabine, and not much else. When a patient got into remission, we had to choose between intensive chemo, autologous stem cell transplant, which means stem cell transplant from your own cells, which we don't do very much anymore, or an allogeneic stem cell transplant, which means a transplant from another individual who you may be related to or not. Now the situation is much more common, and I want to call your attention to the yellow stuff here, which is all new stuff. We can add a pill called midostaurin if they have a FLT3 mutation, so that's personalized medicine. We can add an antibody drug conjugate called GO or gemtuzumab oxytomycin if you have certain chromosomal abnormalities, and we have a new liposomal formulation of daunorubicin and cytarabine we can use in people that have MDS type cytogenetics or MDS type morphology. In the post-remission setting, it's getting a little bit more complicated. We now use transplant for most people except for those with favorable risk. Why do older folks do worse? They clearly do a lot worse. This is one representative older slide, which says that it's very hard to cure an older adult with leukemia. That's because they have less tolerance of intensive therapy, and they have decreased chemotherapy clearance, and they actually have a worse disease in terms of their intrinsic biology of the leukemia. The leukemias that arise in older people are harder to kill. And we sort of divide people by age and also by fitness. It used to be that we would define fitness by the way the patient looked to the doctor. Now we have more sophisticated parameters and techniques to use. In older adults, if they're unfit, we have a new therapy, or if they're older than age 75, it's called HMA venetoclax. And then we'll actually transplant an older adult up to about 75 because they don't do that well with standard chemotherapy. And this is the picture of the liposomal or fat encapsulated chemotherapy we've been using for years that tends to work pretty well. But this new drug called venetoclax has revolutionized the care of older adults with AML because it helps the cells to die in response to cytotoxic stress. And so it can really potentiate or make chemotherapy work better than it did before. And this trial compared the old standard for unfit or older adults called azacitidine, a drug which we use for MDS. We compared that old standard to adding the venetoclax pills. And it turned out that the adding of the pills, the azacitidine, led to a better survival. And median survival is now in the 15-month range, which doesn't sound very good, but that's median, and some people live a lot longer than the median. There's also a new drug called oral azacitidine that can be given in the post-remission setting for people that are older but not undergoing transplants. It also seems to be a benefit. So after they get all their chemotherapy, they can get this oral medicine. So this is also another new drug that's been approved recently in AML. Now, unfortunately, people do relapse even after all the induction chemo, the consolidation chemo, and or the stem cell transplant. But we have some new ways to deal with the relapse. We used to just give standard high-dose chemotherapy and then try to transplant them. Now we have some targeted agents which we can use instead if they have the right mutation. We have a whole bunch of new agents that are being studied. One of the agents that's approved is IDH inhibitors. We have one for IDH1 mutations, one for IDH2 mutations, and each of those drugs has a role to play. In relapsed patients, it's about 20% who have either an IDH1 or an IDH2 mutation. And then we have a FLT3 inhibitor called gilteritinib, which is actually beat chemotherapy. So imagine this, you relapse with AML, you used to give chemotherapy exclusively, now you can take a pill if you have this mutation, the FLT3 mutation, and you do better than you do alone. Now, of course, the median survival for relapsed AML, even with gilteritinib, is not that good, and we're working hard to fix that. And we have some promising new strategies to do that. I'll just talk about a couple. The one on the right is a very interesting idea of an anti-CD47 antibody that covers up a don't eat me signal on the surface of leukemic cells. If you cover up this signal, then the macrophages can kill the leukemia cell. That's kind of neat. On the left, we have APR246, which can actually refold a bad protein, P53, to make it a better actor in that. There's some initial encouraging studies with that. I'm not going to go into the details. There's a third targeted agent called menin inhibitor, which are a class of drugs that work great in mice. The mice who ate the menin inhibitor didn't die, and the mice who didn't eat the menin inhibitor with this targeted leukemia or specific leukemia died. So there's a lot of help on the horizon or hope on the horizon right now. I want to thank all my colleagues at Dana-Farber and elsewhere for helping me with our work on AML. But I wanted to leave everybody with the thought that AML is a serious disease, a disease that's more common in older adults, a disease in which we now use personalized medicine techniques to come up with better therapies and targeted therapies that might be a little easier than standard chemo, which is quite toxic. So I'm very excited to be an AML doctor. I have a lot of hope for the future, and I hope you'll ask me some questions. Thank you so much.